Okay, so this is a young male who came in with trauma and essentially had hypotension, and we were looking at the CT scan. So I'm just going to go through the initial phases here. This is, and the way we do it is we do an arterial phase initially, and then we do a portal venous phase. So I think the first thing you can all appreciate is that there is hemoperitoneum. And if you look very carefully, you see a few punctate drops of air. And I need to look very carefully again because I could barely see it the previous time. So you can see a drop here, maybe a drop there. That may be also just close to the bowel. So you see a couple of few drops of air which just caught our eyes, and we were trying to figure out where the trauma was, and in terms of whether this patient had any other injury. So, and we didn't see anything else in the liver. We didn't see anything in the duodenum. So I'm just going to scroll through the venous phase once and see if you guys can pick out anything which bothers you.
There was something in the mesentery in the pelvis, right? And there was some free air more towards.
Also, I don't like the stranding around the aorta.
Right, absolutely. Mm-hmm. Right. So we knew that he had a significant trauma because you could see this retroperitoneal hemorrhage or fluid around the aorta, and you could see those few focal drops of air that I pointed out earlier. And he clearly has a lot of hemorrhage within the bowel. Sorry, within the intraperitoneal hemorrhage. And I think this case really, the teaching point on this particular case is one needs to look very carefully for bowel pathology when in patients with trauma. And if you see these loops of bowel that you see in the right upper quadrant, for example, you see nice enhancement. And if you look at the images, if you just follow the bowel enhancement lower down, again, you can see reasonably good enhancement here. And then you come to these loops of bowel here and you don't see any enhancement of the wall here at all. So this all bowel, you can see that there's still tubular and you don't, but all of these pelvic loops of bowel are just very difficult to see the wall. And absence of good wall visualization is a little tricky in this patient because of the hemorrhage that you're seeing around it. So sort of similar attenuation, but this is actually very suspicious, particularly given the free air, that he may have bowel injury. So to cut a long story short, this patient did go to the OR and was found to have about 1.2 meters of devitalized ileum from trauma from a mesenteric hemorrhage in the pelvis. I think that's the teaching point here. And they didn't really look at the aorta, so we don't know. We don't have any follow-up on how they're treating the aortic injury or periaortic hematoma that they're seeing here. Probably just follow-up, I guess. But the teaching point was to pick up punctate air and to look for devitalized bowel in trauma patients. Do you guys have any questions or comments?
Nice case. Thank you for sharing.
Okay.
Yeah, we also don't see that much trauma in this conference, so this is wonderful that you've brought it here. And I do have a question. I've seen at some national conferences people talk about dual energy being good for detecting lack of enhancement of the bowel wall. Do you guys use dual energy in your ER at all, or
no? So this is again a nice the coronal plane actually helps you look for differential bowel enhancement. You can see here the right upper quadrant bowel has enhancing well, and you can see this loop, for example, here. This loop is clearly not enhancing, doesn't have a healthy enhancement at all in the pelvis compared to the loops that you're seeing up here. So sometimes the coronal plane actually helps you pick up differential enhancement because it allows you to compare different areas of bowel at the same time. So to answer your question, no, we don't use dual energy for trauma patients, but that's an interesting thought.
You use dual plane, right? Coronal and axial.
We use triple plane, we use coronal, axial,
Yeah.
sagittal and whatever other plane that they choose to give us at that point of time.
Yeah.
Absolutely. Yes. Okay.
Thank you.
We'll stop sharing.
So this is a young lady. The history I got when I started reading this case out was they were pregnant, and at an ultrasound, first trimester ultrasound, it was noted that the sac was, the sac didn't exactly correlate to dates, and they had spotting. They didn't really see a viable gestation, so they went to curettage. And then when the sample from the curettage was sent to pathology, they didn't find any villi within the sample. And so they had a repeat ultrasound, which was unclear as to what is going on. And so they were sent to us for an MRI. I don't have ultrasound images, but I do have MR to share with you. So I'm going to go through these sequences serially, starting with the T2 SAG, as we start reading our routine pelvic MRs. So I'm scrolling from one side to the other. There is a fibroid in the posterior myometrium. The endometrial cavity is distended. There are heterogeneous contents within the endometrial cavity. There is a structure here, which is also predominantly hyperintense on T2 weighted images. And then I'm going to move on to the axial T2s. Scrolling from top to bottom, the right ovary was here. The left ovary is in this region. There's a cyst within the left ovary. And then again, you see this structure on the left side, again, some endometrial contents right here. There was trace free fluid in the pelvis as well. This is the axial T1 weighted sequence. Again, scrolling from top to bottom, on the left side towards the fundus, there are some T1 hyperintense areas. There is some T1 hyperintense signal within the endometrial cavity as well. And lastly, the coronal T2 plane. So, the trainee interpreting this told me there are some blood products within the endometrial cavity. There is a degenerating fibroid here, and then there's another fibroid in the posterior myometrium. And then there is this adnexal cyst. But then I was looking at the SAG, and if you look carefully, the contents in the endometrial cavity, there are blood products, no doubt, because there is T1 and T2 mixed signal within the endometrial cavity, but there almost seems like a thin channel between this structure here and these contents in the endometrial cavity. And then, I was like, why could this not be an ectopic gestation in the cornua or interstitium? And so when we looked at these images, re-looked at these images from that perspective, you notice that this is a predominantly T2 hyperintense structure here, and there are increased vessels in the left adnexa. I think you can see them better in the coronal plane. So if you go back to the coronal plane, there is increased vascularity towards the left cornua, so to speak. And so we raised the possibility that this might be an interstitial ectopic gestation. Some people refer to this as cornual pregnancy as well, or cornual implantation, but truly literature says that you should call these interstitial ectopics rather than cornual, because you don't want to confuse them with gestation within a single horn in a bicornuate uterus. And that one is more often and appropriately referred to as cornual pregnancy. So then they went back to the OR, and knowing this kind of anatomic landmark, the subsequent curettage was successful with villi and everything. So this is my first time I'm seeing like an ectopic, or second time rather. I have a companion case seeing an ectopic gestation on MR. We actually gave contrast as well. I don't know why this was done like a routine pelvis with contrast. I guess the gestation is not viable, so okay to use gadolinium, but there was no additional information necessarily added on the contrast sequences. So, just a few salient features of an interstitial ectopic gestation on an MRI. So one of the things to look for, again, the interstitium is the portion of the fallopian tube within the myometrium where the fallopian tube attaches to the uterus, right? And so one of the features by which you can recognize that this is an interstitial gestation is apparently contiguity with the myometrium, because the implantation is within that intramural portion. And so if you see this kind of contiguity, this is more likely, or this appearance favors an interstitial gestation rather than something called an angular pregnancy. Angular is not in the fallopian tube or cornua, but it's still in the uterus, just at these two corners of the uterus, so to say. And then, yeah, it's important to distinguish interstitial from angular, because interstitial gestations are close to the uterine artery, and if these rupture, they can cause torrential hemorrhage and can be life-threatening as well. So I just thought this was an interesting MR appearance of an interstitial ectopic pregnancy. Any questions on this?
That's a great case, Anu. My question is, they were not able to see it on the pelvic ultrasound, you said?
So no, they saw it on the pelvic ultrasound, but they thought it was an intrauterine gestation. And I was looking through to see how they could have mistaken it to be an intrauterine. Apparently, this can be confused for transvaginal ultrasound as well. It can be confused for an intrauterine gestation. Experienced eyes will be able to distinguish the two, but they can be mistaken for an intrauterine gestation.
Nice. And but when you say intrauterine, but it doesn't look like a normal gestational sac and stuff.
No, they did identify that the gestational sac was abnormal. That's why they went in for a curettage in the first place.
Got it.
Yeah, they did identify that the pregnancy was not progressing normally, and they had also presented with bleeding. So that's why the first round of DNC, and then after we identified the anatomy for them, gave them some more input, then there was a second round of DNC. And this is just a companion case to show you a C-section scar ectopic. So that, again, this abnormal gestational sac with blood products within it is mainly hyperintense on T2-weighted images. I tried looking for any specific features that would point us to what these might look like, and there are no MR pathognomonic features or anything like that. But this was a proven C-section scar ectopic gestation or implantation. That's all I have.
Very nice.
I'm going to stop sharing.
Okay, Tarun.
Okay, so this was like a case I was reviewing on call, and just wanted to scroll from the top here. So concentrate on the upper abdomen. History just
Some
pain.
Bildil and like a transition in the lower bile duct.
Right. So based on that, we thought of a differential diagnosis. And any clues like what you think of right now?
Do you have a coronal to show us?
I do.
Can you stop on the bile duct? I mean, to me, it looks unusual for a cholangio because I can see it going all the way through. I can see the bile duct going through. But there is a transition there.
Right.
And there is like enhancing soft tissue around that area.
Right.
And some hyperdense contents. The cystic duct is also quite dilated, it looks like.
So when I looked at it, my resident had prelimed it like enhancement of the bile ducts and all, and they were thinking like it's some kind of a cholangitis and things like that. What really struck me was that, as you mentioned, Aarti, like there's this transition over here. And I thought that this looked like more like to me a Mirizzi syndrome. And of course, we don't see any stone here or anything like that. But I said that, asked my resident, did you look at some old scans or not? And they did not. And we went back, this from 2018. And this is a gallbladder. And there was a stone right here. That's a cystic duct. And that's the intrahepatic bile duct and the CBD in the pancreatic region. So I said that what's happening here is that most likely there was this stone here, and that time the patient presented with probably some symptoms of gallbladder inflammation. That stone has migrated, most likely. And that's why we are having this kind of a dilatation over here. It's a low cystic duct also looks like. So to prove our point, we asked for a repeat MR. And this is the repeat MR right there.
Nice call.
I think you could see that hyperdense thing in the cystic duct on CT too, you know.
We kind of tried windowing it but
I didn't realize it's stone. I thought maybe it's sludge or something.
Some sludge or something. Yeah. There is a little bit of density here, but it didn't really look like a stone.
It did look like it did not look like a stone on CT. Agreed.
So that was something which basically looking at the old scan really helped a lot, and we could kind of prove a point over with this one. So it's a good teaching case. Without a stone being seen, if you can, I think the critical finding was the abrupt transition. And that's why there is an abrupt transition there. And so something.
Yeah, right at where the cystic duct inserts. That's an awesome call. The gallbladder looks interesting to me on those two MRs, and it makes sense that the gallbladder here is not getting distended because it looks like they have like chronic cholecystitis, which looked more dramatic previously, but because that cystic duct is so distended, but then the gallbladder is not distended. And so it must be because the gallbladder wall is fibrotic.
Fibrotic, exactly. Yep, that's right.
Cool.
Okay. Thank you. I'll stop sharing.
Okay, so this is a patient. They were having some nausea, vomiting. They were having some other issues, but incidentally, we saw this lesion in the liver. It's a big lesion. It's a middle-aged patient. Scroll through some more. Okay, so incidental liver mass, we recommended an MRI. This is the MRI. There's a lot of motion, but it's kind of T2 bright. Just show the diffusion while I'm here. That's not a good diffusion, but you can see this is the DWI. So it's a little bit bright. ADC, kind of intermediate, very bad diffusion. Don't worry about that. Pre-contrast, dark. Moderate enhancement on the arterial phase. Here it is on the delay. It was sort of ISO on the venous, and here it is on the delay. Any thoughts? This is the venous phase. No history of liver disease, although their liver does look a little weird. Okay, I'll give you one more piece of information, which is that we did do an EVIST because we thought, okay, could it be an FNH? It looked kind of arterial enhancing. So this was the delayed phase. And this was the EVIST, 20-minute.
Do GIST show up in the liver? I don't know.
You asked for, do GISTs show up in the liver? They can definitely metastasize to the liver. And I actually think, I remember reading that GIST can be in like ectopic locations. You can even have like a mesenteric GIST because you can have ectopic pacemaker cells in your mesentery. So I'm sure if we Googled it, maybe there would be a GIST in the liver, but this was not a GIST. It's not retaining on the EVIST.
With the T2 again, we were wondering, is there a scar?
What is that making you think of?
These guys were thinking of fibrolamellar or something like that.
No, it doesn't look like.
No.
Doesn't have enhancement like a fibrolamellar. The enhancement is too homogeneous.
Yeah, it's sort of, it did have like arterial enhancement, but it like sort of washed out on the delayed and then it did not retain on EVIST. So, we were thinking, could it be an FNH? The arterial and the venous looked kind of like that, but it's not retaining on the EVIST. So maybe it's not an FNH. So basically we said this was indeterminate. We can't exclude a malignancy. It doesn't look like anything benign, like a cyst or hemangioma, and needs a biopsy. But there is a clue on this scan. I'll show you the CT again. Maybe it'll be easier there.
Stomach wall is a little thick.
Afterwards, you guys are going to be like, oh, yeah.
There's something in the stomach wall, right?
Like this.
Nope.
It's
Wait, where?
splenic tissue, right?
Yeah. So the spleen is missing.
Spleen is
Oh,
missing.
Dad.
Oh.
It happened.
So we biopsied this and it came back.
Atherosclerotic liver, you go down the tubes even faster.
So we biopsied it, it came back splenic tissue. And, I don't know, you could say, is this intrahepatic? We were calling this intrahepatic. When I looked online, you can get, every case of like intrahepatic splenosis that's published online is always at the capsule. So I actually think it's probably like subcapsular / capsular splenosis. But yeah, this tricked us. We did not put it together with the missing spleen. They had trauma like 20 years earlier, but in 75% of cases of splenic rupture, you will find some splenic tissue somewhere in the abdomen. So this one just kind of attached to the capsule and kind of tricked all of us. So the teaching point here is if there's a missing spleen and there's a mysterious mass either somewhere in the abdomen or even attached to the liver, think about splenosis. Then we were talking about it in our group, like, should we have done, instead of biopsy, like, could we have done some nuclear medicine scan? Like, could we have done tagged RBC or a sulfur colloid? So it turns out at our institution, we do not do tagged RBCs anymore because it's very cumbersome to heat damage the RBCs, and sulfur colloid usually gives you the answer. And then we said, like, well, sulfur colloid actually would also be picked up by FNH, but the EVIST had excluded the FNH. So in the end, we could have done a sulfur colloid, which gets picked up by both liver and splenic tissue. And if this thing was hot, we could have just confirmed that this was splenosis. So just a reminder about splenosis. And then I have one more case. This is a cool one. So prostate MR, you can see the prostate here. And then we have this large lesion affiliated with the top of the prostate. Got cystic areas, and then these areas, which actually I will tell you in retrospect are kind of very suggestive of what this is. Someone's typing into the chat. It's an alien.
Is that a SAG?
Yeah, I was going to ask for a SAG. Are the seminal vesicles
and while I
separate?
have it open, I'm just going to show you that there was there was some T1 hyperintensity within it. and it did show enhancement. So I'll just show you the subtractions. These are the subtractions. So there's this kind of modeled enhancement in it. So there's hemorrhage and also modeled enhancement in it. Here's the sagittal. So here's our prostate. And the lesion is kind of affiliated with both the top of the prostate and possibly the seminal vesicles. I'll show you the coronal too if you want it. I know it is kind of gnarly, but it's very cool, right? Doesn't it look like art? It's got lots of interesting elements to it. Okay, any last thoughts? We've actually shown some cases here.
I think, is this some weird stump involving
Yeah. So it's not a stump.
stump
Although,
of the
you know,
seminal vesicles?
No, you know what? This entity might overlap with stump. I gotta do more research about it. But in the past, we did present something called a giant cystadenoma of the prostate. And I will show you, there's a radiographics article about this entity, giant multilocular cystadenoma of the prostate. It was from AIRP in 2015. And you can see, look, it looks kind of like my case, right? It's got like cystic spaces and dark spaces and dark stromal elements. That's a key thing here. And anyway, this actually came back. The diagnosis was a MEST tumor of the seminal vesicle.
Wow.
So the cool thing, my colleague Amir was just found this for me because I was like, oh, it's a MEST tumor. I don't know if you guys remember, I presented a MEST tumor of the kidney a few weeks ago. And Satish told us that there is this spectrum of overlap. So like MCN, multicystic nephroma of the kidney, is now included within this MEST description. But I guess there's also this term MEST you can get in the seminal vesicle. And it seems to me like a similar entity to what you get in the kidney. And they basically are saying that they want to use this term as a unified nomenclature for all these things that we used to call, for example, cystadenoma of the seminal vesicle, mesenchyma, phylloides tumor, etc. So it seems like these are all mesenchymal tumors. They have mixed epithelial and stromal components. So they have glandular elements, which are going to be the T2 hyperintense bright stuff. And then they also have stromal elements that are going to be like the dark bands. And I would say in retrospect, like this lesion looks very similar to the ones I found online for what used to be called like either a giant cystadenoma of the prostate or of the seminal vesicle.
Nice case.
But now called a MEST. Isn't it cool?
Very cool.
Okay, I'm going to stop sharing. Anyone else?
So this one was a little harder because the patient comes from a gastroenterologist that's a hepatologist with a hep C. And, you know, like yours, there's slightly T2 bright lesions here. Not quite as hypo-intense as yours relative to liver. Kind of more ISO. A little hype here, I guess. This is out of phase, in phase. This is T2, a little bit more T2 bright with the fat sat. And then here it is in coronal. And of course, you're not putting together that there's this absent spleen until later on.
Yeah, and especially like since he has liver disease, you're like, okay.
Yeah, exactly. I mean, you see these things and they're like, you're going through your LIRAD stuff, right? So
I mean, technically this would be LIRADS 5. That's like enhancing and washing out background liver disease.
Exactly. It's non-rim arterial phase hyperenhancement, 2 lesions, left lobe. And then, on the delayed, I think I got the delayed here somewhere. Or do I have that's about as delayed as I get. But it does more or less wash out if you do an extreme windowing here. You can almost see encapsulated appearance on that one. And then the other one's a little bit harder to see. But I mean, we figured it out in time to avoid biopsy and stuff. And I don't think we confirmed it in any other way than just following it. And I think we had some remote priors that were like, oh, whoops, we should have looked at those sooner.
Yeah, is there splenosis also in the splenic bed? It seemed like I saw some nodules over there. Okay.
There's some nodules here as well that
Yeah.
are regenerated splenic nodules.
Very nice.
So, but it's easy to go wrong on something like this when you're not in the right mindset.
To Aarti's point, previously, these two are in the periphery as well, right?
Yeah.
Yeah, and most of the splenosis affiliated with the livers and the left lobe, which makes sense because it's like easier to hop over there.
Vicinity.
Yeah, cool. Great companion.